My remit yesterday at the Controversies in Myeloma meeting was to talk about who or which patients may not benefit from a frontline stem cell transplant. Who can we delay the transplant? So I think we have to consider several things. First of all, what are the risks of a stem cell transplant? And whilst stem cell transplantation is a very important part of our myeloma therapy, it is a treatment that has significant morbidity and also a mortality risk of around about 0.5% to 1% of our patients. So clearly, whilst it's a powerful tool, it's also a tool that has issues. Also, we are aware that high-dose melphalan may be a mutagenic agent. It may increase the risk of secondary primary cancers. It may impact on the bone marrow reserve for patients further down their treatment pathway. And also, it renders patients severely neutropenic in this day of antibacterial resistance. Rendering patients severely neutropenic and open to septicemia can increase the danger to them. So we have to think very carefully about how we use this treatment. And my presentation was around which patients may not need a transplant, and particularly looking at those patients who've had very deep responses, who are MRD negative, who have standard risk cytogenetics, who have got the very best responses to treatment. It may well be that those patients don't get a lot of extra benefit from the transplant. And as we look at the alternative treatments to transplant, as they've improved through time, particularly looking at Francesca Guy's Forte study, we can see that 4 cycles of KRD, for instance, achieves the same depth of response as a stem cell transplant. So we really are putting the microscope on who benefits from a transplant and who might not benefit from a transplant.